My name is Sarah Stumbar. I'm a family physician by training. I actually train specifically in family and social medicine, and social medicine is the idea that in order to treat patients, you can't just treat their medical conditions and their physiologic problems, but you also have to treat and look at the communities that they live in. So if you're treating someone for diabetes, you need to consider the food stores that they have available to them and the resources that they have available to them to buy healthy foods. And so kind of as a part of that, I've always been very interested in urban underserved medicine, and I currently see on primarily uninsured patients on a mobile health center and in a few other standing free clinics close to Broward County and Opelika, patients that really struggle, many who are unemployed or don't make a living wage. Many who are uninsured and fall into the Medicaid coverage gap here in Florida. So I do a lot of primary and preventive care, so cancer screenings, pap smears, referrals for mammography. We generally do fecal immunohistochemical testing, or basically testing for blood in the stool instead of colonoscopies, because it is very, very difficult to get colonoscopies for uninsured, otherwise healthy patients in Miami-Dade County. I also see patients for diabetes and high blood pressure and high cholesterol. Those are probably the most common things that we see. I do think that because my patients are uninsured, that we often see diseases that are not as well controlled as you might see in a population that has easy access to medications, where you don't have to stop taking your antidepressant because you don't have the money for it for that month, or where you are left with only kind of older diabetes drugs, which are good but often not sufficient for people as their diseases advance, or very limited types of insulin due to the high cost of insulin. And so often kind of facing diabetes that's a lot more challenging to manage than it would be in someone who has unlimited access to some of the newer designer drugs. Amount of work that has to go into being what we call a well-controlled diabetic. Like, I know that you can do everything right and have every resource at your fingertips the way I am lucky enough to as a physician who has health insurance and an insulin pump. And I sometimes will still wake up with a blood sugar that's 300 and I did everything right the day before. And so I am very sympathetic to my patients who don't have those luxuries and those resources, and how challenging it is for them every single day. They want to do everything right, and the world is just not working for them in that way. I've learned to help people work with what they've got and also respect that effort. And I think that really helps me connect with patients, regardless of the patient population that you see. The reason that most doctors, or many doctors, go into healthcare is that they really believe that healthcare is, I hope that they believe that healthcare is a right rather than a privilege. And we do have a structure, the ability within our country and within our state to expand that access to patients. And I think particularly now we're speaking in the middle of the acute crisis of COVID-19, and we're seeing how when healthcare coverage is tied only to work, we have millions more people who are left without insurance. And so we really need that safety net for our patients as we start to rebuild our economy and our healthcare system, and look at what it means to be healthy again in this country. I'm privileged enough to care for a very disenfranchised portion of our state's residents, people who don't have insurance. And I've been caring for the same people for the last 5 years since I graduated from residency. And a lot of what I've learned over those 5 years is how you work with people to navigate the system and find the resources that are available, and also how to prioritize their healthcare needs. When I had patients who had insurance, you refer to specialists, you order diagnostic studies, and often for my patients, that's just not possible. And sometimes that works out okay. And sometimes it really means that people are going without what they need for months. People are anxious and depressed and concerned about what the future is going to hold. Many people who've been furloughed from work, my patient population tends to work in hotels on Miami Beach or work in event planning and as cater waiters and hotel cleaning people, and most of those jobs don't exist right now. And so that really heightens people's concerns about where they're going to be able to get food from and whether they're going to be able to continue medication. I do have some patients who buy their insurance through the exchanges and are able to do that. And I think that we will see people who are no longer able to pay those costs and those premiums as they start to have to prioritize, immediate needs like food and rent over needs that seem to feel a little bit more hypothetical, like medical needs. Just speaks to the importance of Medicaid expansion, because a lot of those people may fall into the coverage if through Medicaid if expansion were to happen.